typically around 5.5 centimeters. Marfan's, annulo-aortic ectasia, with dilation of the aortic root. Dissection. Recurrent dissections are common, and even triple-barreled dissection can be seen, dissections on both sides of a true channel. Pulmonary artery enlargement. Just like dilation of the aorta, pulmonary artery enlargement favors the root. Loeys-Dietz syndrome. Just think of this as the really shitty version of Marfan's. They have a terrible prognosis, and rupture their aortas all the time. Vessels are very tortuous, twisty. They also have crazy wide eyes, hypertelorism. 423. Ehlers-Danlos. This one is a disorder in collagen, with lots of different subtypes. They have the stretchy skin, hypermobile joints, blood vessel fragility with bleeding diatheses. Invasive diagnostic studies such as conventional angiography and other percutaneous procedures should be avoided because of the excessive risk of arterial dissection. Dissection. Imaging characteristics of aortic aneurysms in Ehlers-Danlos syndrome resemble those in Marfan syndrome, often involving the aortic root. Aneurysms of the abdominal visceral arteries are common as well. Syphilitic, luatic, aneurysm. This is super rare and only seen in patients with untreated tertiary syphilis. There is classically a saccular appearance and involves the ascending aorta as well as the aortic arch aorta. Classic description: saccular asymmetric aortic aneurysm with involvement of the aortic root branches. Often heavily calcified tree bark intimal calcifications. Coronary artery narrowing, at the ostium, is seen 30% of the time. Aortic valve insufficiency is also common. Aortoenteric fistula. These come in two flavors, A, primary, and B, secondary. Primary, very, very, very rare. Refers to an AE fistula without history of instrumentation. They are only seen in the setting of aneurysm and atherosclerosis. Secondary, much more common. They are seen after surgery with or without stent graft placement. The question is usually what part of the bowel is involved, and the answer is third and fourth portions of the duodenum. The second most likely question is AE fistula vs perigraft infection, without fistula. The answer to that is unless you see _contrast from the aorta into the bowel lumen, usually duodenum, you can't tell. Both of them have ectopic perigraft gas, 4 weeks post-repair, both have perigraft fluid and edema, both lose the fat place between the bowel and aorta, tethering of the duodenum to the anterior wall of the aorta, both can have pseudoaneurysm formation. Aortic enteric fistula, primary type. 424. Inflammatory aneurysms, most are symptomatic, more common in young men, and associated with increased risk of rupture regardless of their size. Unlike patients with atherosclerotic AAA, most with the inflammatory variant have an elevated ESR. Their etiology is not well understood but may be related to periaortic retroperitoneal fibrosis or other autoimmune disorders, SLE, giant cell, RA. Smoking is apparently a strong risk factor, and smoking cessation is the first step in medical therapy. In 1/3 of cases, hydronephrosis or renal failure is present at the time of diagnosis because the inflammatory process usually involves the ureters. Imaging findings include a thickened wall, inflammatory or fibrotic changes in the periaortic regions. Often there is asymmetrical thickening of the aorta with sparing of the posterior wall, helps differentiate it from vasculitis. Leerich syndrome refers to complete occlusion of the aorta distal to the renal arteries, most often at the aortic bifurcation. It is often secondary to bad atherosclerosis. There can be large collaterals. Leerich syndrome, complete occlusion of the aorta /distal to the renal arteries. 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 Mid-aortic syndrome refers to progressive narrowing of the abdominal aorta and its major branches. Compared to Leerich, this is higher and longer in segment. It's also a total freaking zebra. It tends to affect children or young adults. This thing is characterized by progressive narrowing of the aorta. LT is not secondary to arteritis or atherosclerosis but instead the result of some intrauterine insult, maybe, with fragmentation of the elastic media. This also has a triad. IHTN, most common presenting symptom. 2 claudication. 3 renal failure. Mid-aortic syndrome, narrow aorta without arteritis or atherosclerosis. 400. Aortic coarctation, this comes in 2 flavors. Infantile, preductal, these guys can have pulmonary edema. More typically a long segment. Blood supply to the descending aorta is via the PDA. Adult, ductal, not symptomatic until later in childhood. Often presents with differential arm forward/leg blood pressures. More typically a short segment. Okay, things to know, strong association with Turner's syndrome, 15 to 20%. Bicuspid aortic valve is the most common associated defect, 80%. They have more berry aneurysms. Figure 3 sign, appearance of CXR. Rib notching, most often involves 4th to 8th ribs. It does not involve the 1st and 2nd because those are fed by the costocervical trunk. Pseudocoarctation, this is a favorite of multiple choice writers. You will have elongation with narrowing and kinking of the aorta. It really looks like a coarctation, but there is no pressure gradient, collateral formation, or rib notching. That is the most likely question. The second most likely question is the area of aneurysmal dilation may occur distal to the areas of narrowing in pseudocoarctation, and they may become progressively dilated and should therefore be followed. Thoracic outlet syndrome, congenital or acquired compression of the subclavian vessels, artery and vein, and brachial plexus nerves as they pass through the thoracic inlet. It is a spectrum, nerve, 95%, subclavian vein, subclavian artery, with symptoms varying depending on what is compressed. Compression by the anterior scalene muscle is the most common cause. However, cervical rib, muscular hypertrophy, fibrous bands, Paget's, tumor etc. can all cause symptoms. Treatment is usually surgical removal of the ribeye muscle. The classic way to show this is arms up and arms down angiography. Occlusion occurs with arms up. Paget-Schroeder, this is essentially thoracic outlet syndrome, with development of a venous thrombus in the subclavian vein. It's sometimes called effort thrombosis because it's associated with athletes, pitchers, weightlifters, who are raising their arms a lot. They will use catheter-directed lysis on these dudes, and surgical release of the offending agent as above. Stenting isn't usually done, and can only be done after surgery.
Above. Stenting isn't usually done, and can only be done after surgery to avoid getting the stent crushed. 426. Pulmonary artery aneurysm / pseudoaneurysm. Think about 3 things for multiple choice. 1. Iatrogenic from Swan-Ganz catheter * most common. 2. Baysets. 3. Chronic PE. When they want to lead Swan-Ganz they may say something like patient in the ICU. The buzzwords for Baysets are Turkish descent and mouth and genital ulcers. For Baysets are Turkish descent and mouth and genital ulcers. Hughes-Stoving syndrome. This is a zebra cause of pulmonary artery aneurysm that is similar, and may be the same thing, as Baysets. It is characterized by recurrent thrombophlebitis and pulmonary artery aneurysm formation and rupture. Rasmussen aneurysm. This has a cool name, which instantly makes it high yield for testing. This is a pulmonary artery pseudoaneurysm secondary to pulmonary TB. It usually involves the upper lobes in the setting of reactivation TB. Tetralogy of phallic repair gone south. So another possible testable scenario is the patch aneurysm from the RVOT repair. Splenic artery aneurysm, the most common visceral arterial aneurysm. They can be true or false. The true ones are associated with HTN, portal HTN, cirrhosis, liver transplant, and pregnancy. More common in pregnancy, and more likely to rupture in pregnancy. In contrast to normal aneurysms, atherosclerosis is not considered the underlying cause. Most are located in the distal artery. False aneurysms are associated with pancreatitis. An important mimic is the islet cell pancreatic tumor, which is hypervascular. Don't be a dumbass and try and biopsy the aneurysm. If you are forced to choose which ones to treat, I guess I'd go with anything over 2 centimeters, any false one, and anyone in a woman planning on getting pregnant. Median arcuate ligament syndrome, Dunbar syndrome. This is compression of the celiac artery by the median arcuate ligament, fibrous band that connects the diaphragm. Most people actually have some degree of compression, but it's not. Pulmonary artery aneurysm, pseudoaneurysm. Think about 3 things for multiple choice. 1. Iatrogenic from Swan-Ganz catheter * most common. 2. Baysets. 3. Chronic PE. When they want to lead Swan-Ganz they may say something like patient in the ICU. The buzzwords for Baysets are Turkish descent and mouth and genital ulcers. Hughes-Stovin syndrome. This is a zebra cause of pulmonary artery aneurysm that is similar, and may be the same thing, as Baysets. It is characterized by recurrent thrombophlebitis and pulmonary artery aneurysm formation and rupture. Rasmussen aneurysm. This has a cool name, which instantly makes it high yield for testing. This is a pulmonary artery pseudoaneurysm secondary to pulmonary TB. It usually involves the upper lobes in the setting of reactivation TB. Tetralogy of phallic repair gone south. So another possible testable scenario. Tetralogy of phallic repair gone south. So another possible testable scenario is the patch aneurysm from the RVOT repair. Splenic artery aneurysm. aneurysm, the most common visceral arterial aneurysm. They can be true or false. The true ones are associated with HTN, portal HTN, cirrhosis, liver transplant, and pregnancy. More common in pregnancy, and more likely to rupture in pregnancy. In contrast to normal aneurysms, atherosclerosis is not considered the underlying cause. Most are located in the distal artery. False aneurysms are associated with pancreatitis. An important mimic is the islet cell pancreatic tumor, which is hypervascular. Don't be a dumbass and try and biopsy the aneurysm. If you are forced to choose which ones to treat, I guess I'd go with anything over 2 centimeters, any false one, and anyone in a woman planning on getting pregnant. Median arcuate ligament syndrome, Dunbar syndrome. This is compression of the celiac artery by the median arcuate ligament, fibrous band that connects the diaphragm. Most people actually have some degree of compression, but it's not a syndrome until there are symptoms, abdominal pain, weight loss. Typical age is 20 to 40 years old. The buzzword is hooked appearance. It's classically shown on angiography, and they will want you to know that it gets worse with expiration. It can actually lead to the development of pancreaticoduodenal collaterals and aneurysm formation. It's treated surgically. Median arcuate ligament. 427. Section 4. Mesenteric leukemia. This can be broadly classified as acute or chronic. Chronic. Chronic, significant stenosis of 2 out of 3 main mesenteric vessels and symptoms, food fear, LUQ pain after eating, pain out of proportion to exam. Some practical pearls are that you can have bad disease, and no symptoms, if you have good collaterals. Alternatively, if you have bad one-vessel disease, you can have symptoms, if you have crappy collaterals. Remember that the splenic flexure is the most common because it's the watershed of the SMA and IMA. Acute, this comes from 4 main causes. Arterial, venous, hypovolemic, and strangulation. Arterial, occlusive emboli, usually more distal, at branch points, or thrombus, usually closer to the ostium. Vasculitis can also cause it. The SMA is most commonly affected. Arterial typically has a thinner wall, no arterial inflow, and is not typically dilated. After reperfusion, the bowel wall will become thick with a target appearance. Venous, dilation with wall thickening, 8 to 9 millimeters, with 5 millimeters being normal, is more common. Fat stranding and ascites are especially common findings in venous occlusion. Non-occlusive, seen in patients in shock or on pressors. This is the most difficult to diagnose on CT. The involved segments are often thickened. Enhancement is variable. Look for delayed filling of the portal vein at 70 seconds. Strangulation, this is almost always secondary to a closed loop obstruction. Obstruction. This is basically a mixed arterial and venous picture. 427. Section 4. Mesenteric leukemia. This can be broadly classified as acute or chronic. Chronic, significant stenosis of 2 out of 3 main mesenteric vessels and symptoms, food fear, LUQ pain after eating, pain out of proportion to exam. Some practical pearls are that you can have bad disease and no symptoms if you have good collaterals. Alternatively, if you have bad one vessel disease, you can have symptoms if you have crappy collaterals. Remember that the splenic flexure is the most common because it's the watershed of the SMA and IMA. Acute, this comes from 4 main causes. Arterial, venous, hypovolemic, and strangulation. Arterial, occlusive emboli, usually more distal, at branch points, or thrombus, usually closer to the ostium. Vasculitis can also cause it. The SMA is most commonly affected. Arterial typically has a thinner wall, no arterial inflow, and is not typically dilated. After reperfusion, the bowel wall will become thick with a target appearance. Venous, dilation with wall thickening, 8 to 9 mm, with 5 mm being normal, is more common. Fat stranding and ascites are especially common findings in venous occlusion. Non-occlusive, seen in patients in shock or on pressors. This is the most difficult to diagnose on CT. The involved segments are often thickened. Enhancement is variable. Look for delayed filling of the portal vein at 70 seconds. Strangulation, this is almost always secondary to a closed loop obstruction. This is basically a mixed arterial and venous picture with congested dilated bowel. Hemorrhage may be seen in the bowel wall. The lumen is often fluid-filed. Arterial mesenteric leukemia 1, I venous ___I___ strangulation _L, occlusive 1 thin bowel wall, thick after reperfusion. Section 5. 5. Mesenteric miscellaneous. This is my general algorithm if I see angry bowel. Colitis I enteritis. Infection diffuse or TL. Inflammatory TL. Ischemic arterial, comma. Occlusive non-occlusive. Embolic branch points thrombotic closer to ostium. Think hypertension, watershed A. Watershed A. Watershed A. Watershed A. Colonic angiodysplasia. This is the second most common cause of colonic arterial bleeding, diverticulosis being number 1. This is primarily right-sided with angiography demonstrating a cluster of small arteries during the arterial phase, along the antimesenteric border of the colon, with early opacification of dilated draining veins that persists late into the venous phase. There is an association with aortic stenosis which carries the eponym Hayde syndrome, which instantly makes it high yield for multiple choice. Colonic angiodysplasia. 429. Osler. Osler. Osler-Weber-Rondeau, hereditary hemorrhagic telangiectasia. 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 This is an AD multisystem disorder characterized by multiple AVMs. On step L they used to show you the tongue eye mouth with the telangiectasis, and a history of recurrent bloody nose. Now, they will likely show multiple hepatic AVMs or multiple pulmonary AVMs. Extensive shunting in the liver can actually cause biliary necrosis and bile leak. They can have high output cardiac failure. Most die from stroke or brain abscess. Gamesmanship. Next step, if the syndrome is suspected, these guys need CT of the lung and liver with contrast, plus a brain Mr. IMRA. Osler-Weber-Rondeau, hereditary hemorrhagic telangiectasia. Renal artery stenosis. Narrowing of the renal artery most commonly occurs secondary to atherosclerosis. 420. Osler-Weber-Rondeau, hereditary hemorrhagic telangiectasia. This is an AD multisystem disorder characterized by multiple AVMs. On step L they used to show you the tongue eye mouth with the telangiectasis, and a history of recurrent bloody nose. Now, they will likely show multiple hepatic AVMs or multiple pulmonary AVMs. Extensive shunting in the liver can actually cause biliary necrosis and bile leak. They can have high output cardiac failure. Most die from stroke or brain abscess. Gamesmanship. Next step, if the syndrome is suspected, these guys need CT of the lung and liver with contrast, plus a brain Mr. IMRA. Osler-Weber-Rondeau, hereditary hemorrhagic telangiectasia. Renal artery stenosis. Stenosis. Narrowing of the renal artery most commonly occurs secondary to atherosclerosis, 75%. This type of narrowing is usually near the ostium and can be stent. FMD is the second most common cause and typically has a beaded appearance sparing the ostium, should not be stent. Additional more rare causes include PAN, Takayasu, NF1, and radiation. FMD, fibromuscular dysplasia, a non-atherosclerotic vascular disease, primarily affecting the renal arteries of young white women. Things to know. Renovascular HTN in young women equals FMD. Renal arteries are the most commonly involved, carotid number 2, iliac number 3. There are 3 types, but just remember medial is the most common, 95%. They are predisposed to spontaneous dissection. Buzzword equals string of beads. Treatment equals angioplasty without stenting. 430. Nutcracker syndrome, smashing of the left renal vein as it slides under the SMA, with resulting abdominal pain, left flank, and hematuria. The left renal vein gets smashed a lot, but it's not a syndrome without symptoms. Since the left gonadal vein drains into the left renal vein, it can also cause left testicle pain in men, and LLQ pain in women. Women. Nutcracker, renal vein, smashed by SMA. Note the prominent venous collateral. SAM, segmental arterial Mediolysis affects the splanchnic arteries in the elderly and the coronaries in young adults. Not a true vasculitis, with no significant inflammation. It's complicated, but essentially the media of the vessel turns to crap, and you get a bunch of aneurysms. The aneurysms are often multiple. The way this is shown is multiple abdominal splanchnic artery saccular aneurysms. This is the disease hallmark. Pelvic congestion syndrome. This is a controversial entity, sometimes grouped in the fibromyalgia spectrum. Patients often have chronic abdominal pain. They also often wear a lot of rings and drink orange soda. The classic demographic is a depressed, multiparous, premenopausal women with chronic pelvic pain. Venous obstruction at the left renal vein, nutcracker compression, or incompetent ovarian vein valves leads to multiple dilated parauterine veins. This very real diagnosis can be treated by your local interventional radiologist via ovarian vein embolization. 431. Testicular varicocele, abnormal dilation of veins in the pampiniform plexus. Most cases are idiopathic and most, 98%, are found on the left side. Left vein is longer and drains into renal vein at right angle. They can also occur on the left, secondary to the above-mentioned nutcracker syndrome. They can cause infertility. Non-decompressible is a buzzword for badness. Some sources state that neoplasm is actually the most likely cause of non-decompressible varicocele in men over 40 years of age, left renal malignancy invading the renal vein. Right-sided varicocele can be a sign of malignancy as well. When it's new and on the right side in an adult, you should raise concern for a pelvic or abdominal malignancy. New right-sided varicocele in an adult should make you think renal cell carcinoma, retroperitoneal fibrosis, or adhesions. Non-decompressible equals bad. Right equals bad. Left equals okay. Bilateral equals okay. Okay, probably. Probably. Gamesmanship. This diagnosis is the classic next step question of all next step questions, because you need to recognize when this common diagnosis is associated with something bad. Isolated right varicocele equals get an ABDCT, or MR, or US. Non-decompressible varicocele equals get an ABDCT, or MR, or US. Bilateral decompressible varicoceles equals might need treatment if infertile, etc. etc. But doesn't need additional cancer hunting imaging. Isolated left varicocele equals might need treatment if infertile, etc. But doesn't need additional cancer hunting imaging. Uterine AVM, this can present with life-threatening massive genital bleeding. Bleeding. Rarely they can present with CHF. They come in two flavors: A, congenital, and B, acquired. Acquired occurs after D&C, abortion, or multiple pregnancies. They are most likely to show this on color Doppler with serpiginous structures in the myometrium, with low resistance high-velocity patterns. This one needs embolization. Could look similar to retained products of conception. Clinical history will be different. different, and RPOC is usually centered in the endometrium rather than the myometrium. 432. Section 6 Extremity. May-Thurner, a syndrome resulting in DVT of the left common iliac vein. The pathology is compression of the left common iliac vein by the right common iliac artery. Treatment is thrombolysis and stenting. If they show you a swollen left leg, this is probably the answer. Popliteal aneurysm, this is the most common peripheral arterial aneurysm, 2D most common. Overall, to the aorta. The main issue with these things is distal thromboembolism, which can be limb-threatening. There is a strong and frequently tested association with AAA. 30 to 50% of patients with popliteal aneurysms have a AAA. 0% of patients with AAA have popliteal aneurysms. 50 to 70% of popliteal aneurysms are bilateral. The most dreaded complication of a popliteal artery aneurysm is an acute limb from thrombosis and distal embolization of thrombus pooling in the aneurysm. Popliteal entrapment, symptomatic compression, or occlusion of the popliteal artery due to the developmental relationship with the medial head of the gastrocnemius, less commonly the popliteus. Medial deviation of the popliteal artery is supposedly diagnostic. This usually occurs in young men, 30. These patients may have normal pulses yet decrease with plantar flexion or dorsiflexion of the foot. They will show you either a MRA or conventional angiogram in rest and then stress, dorsii plantar flexion, to show the artery occlude. Hypothenar hammer, caused by blunt trauma, history of working with a jackhammer, to the ulnar artery and superficial palmar arch. The impact occurs against the hook of the hamate. Arterial wall damage leads to aneurysm formation with or without thrombosis of the vessel. Emboli may form, causing distal obstruction of digits. Digits, this can cause confusion with the main DDX burgers. Look for corkscrew configuration of the superficial palmar arch, occlusion of the ulnar artery, or pseudoaneurysm off the ulnar artery. Peripheral vascular malformations. About 40% of vascular malformations involve the extremities, the other 40% are head and neck, and 20% is thorax. Different than hemangiomas, vascular malformations generally increase proportionally as the child grows. This dude Jackson classified vascular malformation as either low flow or high flow. Low flow would include venous, lymphatic, capillary, and mixes of the like. High flow has an arterial component. Treatment is basically determined by high or low flow. 433. Klippel-Trenaunay syndrome, KTS. This is often combined with Parkes-Weber, which is a true high-flow AV malformation. KTS has a triad of port wine nevi, bony or soft tissue hypertrophy, localized gigantism, and a venous malformation. A persistent sciatic vein is often associated. The marginal vein of Serval, some superficial vein in the lateral calf and thigh, is pathognomonic. It's basically a great saphenous on the wrong side. Additional trivia, 20% have GI involvement and can bleed. If the system is big enough it can eat your platelets, Kasabach merit. Basically, if you see a MRA/MRV of the leg with a bunch of superficial vessels and no deep drainage, you should think about this thing. KTS equals low flow, venous. Parkes-Weber equals high flow, arterial. Klippel-Trenaunay-Weber equals something people say when they A. don't know what they are talking about, or B. don't know what kind of malformation it is, and want to use a blanket term. ABIs, so basic familiarity with the so-called ankle to brachia index, can occasionally come in handy with regard to peripheral arterial disease. This is basically a ratio of systolic pressure in the leg over systolic blood pressure in the arm. Diabetics can sometimes have unreliable numbers because dense vascular calcifications won't let the vessels compress. 1.0 equals normal, 0.5 to 0.3 equals claudication, 0.3 equals rest pain. Intimal hyperplasia, the bane of endovascular intervention. This is not a true disease but a response to blood vessel wall damage. Basically this is an exuberant healing response that leads to intimal thickening which can lead to stenosis. You hear it talked about the most in IR after they have revascularized a limb. Restenosis that occurs 3 to 12 months after angioplasty is probably from intimal hyperplasia. It's sneaky to treat and often resists balloon dilation and slash or reoccurs. If you put a bare stent in place it may grow through the cracks and happen anyway. If you put a covered stent in, it may still occur at the edges of the stent. The take-home point is that it's a pain in the ass, and if they show an angiogram with a stent in place that now appears to be losing flow, this is probably the answer. Intimal hyperplasia, dark stuff growing along the inside of the stent walls. 434. 434. Cystic adventitial disease, this uncommon disorder classically affects the popliteal artery of young men. Basically you have one or multiple mucoid-filled cysts developing in the outer media and adventitia. As the cysts grow they compress the artery. MIP-CTA showing vascular narrowing, fluid-sensitive MR showing a much of cysts around the vessel, extrinsically narrowing it. 435. Section 1. Vasculitis. Basically all vasculitis looks the same, with wall thickening, occlusions, dilations, and aneurysm formation. The trick to telling them apart is the age of the patient, the gender race, and the vessels affected. Classically, they are broken up into large vessel, medium vessel, small vessel ANCA plus, and small vessel ANCA negative. Large. Takayasu, the pulseless disease. This vasculitis loves young Asian girls, usually 15 to 30 years old. If they mention the word Asian, this is likely to be the answer. Also, if they show you a vasculitis involving the aorta, this is likely the answer. In the acute phase there will be both wall thickening and wall enhancement. There can be occlusion of the major aortic branches, or dilation of the aorta and its branches. The aortic valve is often involved, can cause stenosis or AL. In the late phase there is classically diffuse narrowing distally. The pulmonary arteries are commonly involved, with the typical appearance of peripheral prum. If anyone was a big enough jerk to ask, there are 5 types with variable involvement of the aorta and its branches. Which type is which is beyond the scope of the exam, just know type 3 is most common, involves arch and abdominal aorta. Takayasu, wall thickening involving the aorta. 436. Giant cell, the most common primary system vasculitis. This vasculitis loves old men. Men, usually 70 to 80. This vasculitis involves the aorta, and its major branches, particularly those of the external carotid, temporal artery. This can be shown in 2 ways, 1 an ultrasound of the temporal artery, demonstrating wall thickening, or a 2 CTA-IMRA, or even angiogram of the armpit area, subclavian/axillary/brachial, demonstrating wall thickening, occlusions, dilations, and aneurysm. Think about it as the part of the body that would be compressed by crutches. Old men need crutches. Trivia worth knowing is that ESR and CRP are markedly elevated, and that the disease responds to steroids. Gold standard for diagnosis is temporal artery biopsy, although it's often negative. Giant cell, armpit vessel thickening. Giant cell, the most common primary system vasculitis. This vasculitis loves old men, usually 70 to 80. This vasculitis involves the aorta, and its major branches, particularly those of the external carotid, temporal artery. This can be shown in two ways: 1, an ultrasound of the temporal artery, demonstrating wall thickening, or 2, CTA-IMRA, or even angiogram of the armpit area, subclavian/axillary/brachial, demonstrating wall thickening, occlusions, dilations, and aneurysm. Think about it as the part of the body that would be compressed by crutches. Old men need crutches. Trivia worth knowing is that ESR and CRP are markedly elevated, and that the disease responds to steroids. Gold standard for diagnosis is temporal artery biopsy, although it's often negative. Giant cell, armpit vessel thickening. Cogan syndrome, total zebra, probably not even worth mentioning. It is a large vessel vasculitis that affects children and young adults. It likes the eyes and ears, causing optic neuritis, uveitis, and audiovestibular symptoms resembling Meniere's. They can also get aortitis, and those that do have a worse prognosis. Basically, kid with eye and ear symptoms and or aortitis. 437. Medium. Pan. Giant cell, armpit vessel thickening. Cogan syndrome, total zebra, probably not even worth mentioning. It is a large vessel vasculitis that affects children and young adults. It likes the eyes and ears, causing optic neuritis, uveitis, and audiovestibular symptoms resembling Meniere's. They can also get aortitis, and those that do have a worse prognosis. Basically, kid with eye and ear symptoms and or aortitis. 437. Medium. Pan, polyarteritis nodosa. This is one of two vasculitides, the other being Buerger's, that is more common in men. Pan is more common in a man. This can affect a lot of places, with the big three being renal, 90%, cardiac, 70%, and GI, 50 to 70%. Typically we are talking about microaneurysm formation, primarily at branch points, followed by infarction. I would expect this to be shown either as a CTA, or angiogram of the kidneys with microaneurysms, or a kidney with areas of infarct, multiple wedge-shaped areas. Trivia to know is the association with Hep B. Also, as a point of trivia, the microaneurysm formation in the kidney can also be seen in patients who abuse crystal meth, sometimes called a speed kidney. Kawasaki disease, probably the most common vasculitis in children. Children, HSB also common. Think about this as a cause of coronary vessel aneurysm. Aneurysm. A calcified coronary artery aneurysm shown on CXR is a very rare and mini. Other trivia includes the buzzwords mucocutaneous lymph lymph node syndrome and fever. For 5 days. Coronary artery aneurysms, 8 mm, are giant and prone to badness, including MI. Coronary artery aneurysms, 8 mm, may regress. 438. Small vessel disease, ANCA plus. Wegener's, I think about upper respiratory tract sinuses and lower respiratory tract lungs and kidneys. CANCA is plus 90% of the time. Ways this is shown are the nasal perforation, like a cocaine addict, and the cavitary lung lesions. Churg-Strauss, this is a necrotizing pulmonary vasculitis, which is in the spectrum of eosinophilic lung disease. They always have asthma and eosinophilia. Transient peripheral lung consolidation, or ground glass regions, is the most frequent feature. Cavitation is rare. This should make you think Wegener's instead. They are PANCA plus 75% if time. Vocab Updale. You aren't supposed to say a Wegener, apparently he was a Nazi. Instead say granulomatosis with polyangiitis. You know who else was a Nazi? 1 LCNRY Ford. No one ever talks about that. Google it. He wrote a book called The Ultimational.kw, The World I Formo, IL Problem. And got a 1-1 award. From JLit/ER. Eosinophilia. Transient peripheral lung consolidation, or ground glass regions, is the most frequent feature. Cavitation is rare. This should make you think Wegener's instead. They are PANCA plus 75% if time. Vocab Updale. Make you think Wegener's instead. They are PANCA plus 7. Small vessel disease, ANCA. HSP, Henox-Glunline purpura, the most common vasculitis in children, usually age 4 to 11. Although it is a systemic disease, GI symptoms are most common: pain, blood, diarrhea. It is a common lead point for intussusception. They could show this two classic ways: 1, ultrasound with a donut sign for intussusception, or 2, as an ultrasound of the scrotum showing massive skin edema. A less likely, but also possible, way to show this case would be multifocal bowel wall thickening, or a plain film with thumb printing. BEL1CETS, classic history is mouth ulcers and genital ulcers in someone with Turkish descent. It can cause thickening of the aorta, but for the purpose of multiple choice test, I expect the question will be pulmonary artery aneurysm. Burgers, this vasculitis is strongly associated with smokers. It affects both small and medium vessels in the arms and legs, more common in legs. Although it is more commonly seen in the legs, it is more commonly tested with a hand angiogram. The characteristic features are extensive arterial occlusive disease with the development of corkscrew collateral vessels. It usually affects more than one limb. Buzzword equals autoamputation. 439. Gamesmanship hand angiograms. If they are showing you a hand angiogram, it's going to be either Burgers of Hypothenar HAN1MER. Burgers of Hypothenar HAN1MER syndrome, HHS. My strategy centers around the ulnar artery. 1. Ulnar artery involved equals HJ is. The most helpful findings is a pseudoaneurysm off the ulnar artery. This is a SLAM DTLLLK for HHS. 2. Ulnar artery looks okay, then look at the fingers. If they arc out, go with Bierkurs. It sure would be nice to see some corkscrew collaterals to make it sure thing. Be careful because the fingers can be out with HHS as well, distal emboli, but the ulnar artery should be fucked. Look at that ulnar artery first. Takayasu. 440. Large vessel. Tak Ayasa young Asian female, thickened aneurysmal Section 8, Eroded Doppler. There are a couple of high-yield topics regarding carotid Doppler. Stenosis, they will show you an elevated velocity, normal is 125 cm/s. They may also show you ICA/CCA ratio, normal is 2, or the ICA and diastolic velocity, 40 is normal. Here are the rules. Less than 50% stenosis will not alter the peak systolic velocity. 50 to 69% stenosis, ICA psi 125-230 cm/s, ICA/CCA psi ratio, 2.0 to 4.0, ICA eddy 40 to 100 greater than 70% stenosis, ICA psi, 230 cm/s, ICA/CCA psi ratio, greater than 4.0, ICA eddy, 100 proximal stenosis. Okay, here is the trick. They will show tardus parvus waveform. If they show it unilateral, it is stenosis of the innominate. If it's bilateral, then it's aortic stenosis. Subclavian steal, this is discussed in greater detail in the cardiac chapter, but this time let's show it on ultrasound. As a refresher, we are talking about stenosis and or occlusion of the proximal subclavian artery with retrograde flow in the ipsilateral vertebral artery. How will they show it? They are going to show two things: 1, retrograde flow in the left vertebral, and 2, a stenosis of the subclavian with a high velocity. How they can get really sneaky. They can show this thing called early steal. Steal is apparently a spectrum, which starts with mid-systolic deceleration with antegrade late systolic velocities. Some people think the early steal waveform looks like a rabbit. To and fro flow, incomplete steal. V/back. Gamesmanship: internal carotid vs external carotid. Carotid. This really lends itself well to multiple choice test questions. The big point to understand is that the brain is always on. You need blood flow to the brain all the time. Which means diastolic flow needs to be present all the time, and thus continuous color flow throughout the cardiac cycle. The external carotid feeds face muscles, they only need to be on when you cat and talk. Internal carotid low resistance, low syilic velocity diastolic velocity, does not return to baseline. External carotid ili resistance, high systolic velocity diastolic velocity approaches zero baseline. Continuous color flow is seen throughout color flow is intermittent during the cardiac cycle. Temporal tap, it is a technique sonographers use to tell the External carotid from the internal carotid. You tap the temporal artery on the forehead and look for ripples in the spectrum. The tech will usually write TR on the strip when they do this. Asterisk foo can also look slash or branches to tell the external carotid vs the internal. 443. Aortic regurgitation. Just like aortic stenosis, they are going to show you bilateral CCAs. In this case, you are going to get reversal of diastolic flow. Brain death. Apparently in the ever-feuding monarchies of Europe, ultrasound can be used for brain death studies. A loss of diastolic flow suggests cessation of cerebral blood flow. Aneurysms. In case someone asks you, distal formation of an aneurysm, such as one in the skull, cannot be detected by ultrasound because proximal flow is normal. Intra-aortic balloon pump. Remember these guys are positioned so that the superior balloon is 2 centimeters distal to the takeoff of the left subclavian artery, and the inferior balloon is just above the renals. You don't want it occluding importing stuff when it inflates. When the balloon does inflate, it will displace the blood in this segment of the aorta, smashing it superior and inferior to the balloon. The balloon will inflate during early diastole, right after the aortic valve closes, because this is when the maximum amount of blood is available for displacement. What does this do to the internal carotid, CA, waveform? You are going to see an extra bump or augmentation as the balloon inflates and displaces blood superior. Pump/inflates. Which wave would you measure to evaluate the velocity? The first one, the one that is not assisted. 444. Classic carotid Doppler cases. Normal peak velocity 60 to 1 OECM/s. Continuous diastolic flow. Lower peak velocity,